questions, right? So best prognosis among all AML is what? Best prognosis is M3. This is the answer. Commonest form of subtype is M2, right? DIC common in which AML? M3, right? How to categorize AML by risk factor? We will see it. How to treat the high risk AML? That we will see it. So high risk AML, usually we give the induction chemotherapy or chemotherapy which clears the all blast cell followed by the bone marrow transplant, especially in the high risk. And what is the ATRA and where it is used in AML? So ATRA is called as all trans retinoic acid. It's a vitamin A derivatives and it helps in AML M3 or APML or AML M3 subcategory, and that helps to control the excessive proliferation of promyelocyte. So it keeps leukemia under control. So now this is the literature. Which AML, the frequency of DIC known as particularly higher in M3, such as acute promyelocytic leukemia, APL is most frequently associated with a hyperfibrinolytic type DIC and present with bleeding manifestation or DIC basically. So APML M3, what's the percentage among M0 to M7? It's 10%. In more than 90%, you can see translocation 15, 17, I told you, right, is a diagnostic point, and they present with the DIC in almost 20% of the patient or hemorrhage. So this is what the literature is. This is again the FAB classification. I already told you FAB stands for French, American, British, right? This is what the given in the book. And also there is a one more classification by WHO, but by and large both are same. So if you can see, the most highest percentage is M2. So if they ask you in the exam which is the most commonest AML amongst M0 to M7, then answer is M2. They ask what is the best prognosis, then it is M3, but percentage is just 5%, right? You can see. So these are the all various type. There is a name also given. M3 is the acute promyelocytic leukemia, myelomonocytic leukemia, right? So, but you don't need to remember. We are going to go for GP, but just you need to know the basic thing. It this comes how you manage. So this is all questions I already answered you, right? So how you treat the high risk? So I told you chemotherapy followed by bone marrow transplant, especially because there is a high risk of recurrence or relapse. But let me tell you one thing which is very myth in your mind, that oh, AML or acute leukemia or blood cancer cannot be treated. So let me tell you, gentlemen, leukemia, especially acute leukemia, means blood cancer, curable, absolutely curable. So whenever patient comes to you and say, "Oh, doctor, I have leukemia," so don't get disappointed first by your own that oh, leukemia now he will die in 3 6 months. So completely remove that thoughts from your mind. Leukemia is absolutely treatable, absolutely curable with good prognosis, right? And if somebody has APL M3, as I told you, there are 80% chance that patient may go in remission, means bone marrow is completely clear. That is called remission. And eventually, if you give consolidation chemotherapy after induction chemotherapy, 50% plus patient cure forever, completely free of leukemia. So it's a very important take home message from my side as well, right? That leukemia is curable. So get this idea out that it is now not incurable. I knows and untreated hundreds and hundreds of patients in my 20 years of practice. Lots of patients are now live and they are living the normal healthy lifestyle. So that's it. Any question so far? Any question? Anyone? Dr. Reshma, any question? Dr. Raksha? Dr. Bahar, any question? Fine. So if it is no questions, I will switch to the next questions, right? So you can post your whatever your concern is there, you can post in the chat box as well, right? So don't get worried. So this is the second questions in front of your screen. A 2-year-old child comes with ear discharge, seborrheic dermatitis, polyuria, and hepatosplenomegaly. Which of the following is most likely diagnosis? Leukemia, lymphoma, Langerhans cell histiocytosis, germ cell tumor. Here I need the two answer from you. What's the diagnosis of this patient and what is the treatment, or how you gonna treat this patient if comes in your OPD? Take your time. If you shy to give me the answer directly, post in the chat box. No need to shy. Try to think if the same question comes in your exam, how you gonna approach. Yes, do little brainstorm. What do you think? What could be the answer? And then when you give the answer, try to justify that. Okay, fine. This is the perfect answer. I want everyone to get involved, not just one candidate. It's a learning platform, so try to discuss. If we discuss, yes, Dr. Rishabh Amin, can you little discuss this if you don't mind? Dr. Rishabh Amin, you can unmute your mic now. Are you there? Fine. So the answer. Why it is not Dr. Bahar Toprak? Why it is not a leukemia or lymphoma?
Because we don't wait air discharge or seborrheic dermatitis or pylori. We wait ecchymosis, purpura,
Mhm.
hemostasis, BTS, but now other symptoms.
No. Okay. Fine. Fair enough. So basically, when we are, say, for example, when we are ruling out, so say for leukemia, if it is a leukemia patient, what it so it is a 2 years. So if it is a leukemia, usually at 2 years of age, usually if it is leukemia, it is ALL, that is acute lymphoblastic leukemia. But what happens, right? Here there is a blood or bone marrow, there is a more than 20% of the blast cell, which is not there, right? Hepatosplenomegaly can be there, but there is no usually no ear discharge in acute leukemia. There is no seborrheic dermatitis, right? There is nothing related with the CBC is not given. Not given means it is normal. There is no thrombocytopenia. There is no bleeding. There is no ecchymosis. There is nothing which is pointing towards leukemia. If it is lymphoma, then what could be in the lymphoma? So lymphoma at 2 years of age is very rare, not very common at 2 years of age. Number two, lymphoma only you can see hepatosplenomegaly, but before that you can also see lymphadenopathy, which is not there, right? There is a B symptoms. If you know the B symptoms, there are three symptoms in B symptoms: fever, night sweat, and weight loss. This is the three symptoms. In book it is given as a B symptom. So what do you mean by B symptoms, right? So compilation of three things: fever, night sweat, and weight loss. 5% plus unintentional weight loss, it is defined as a weight loss, right? So fever, night, and weight loss is the B symptoms usually present in lymphoma, which is not present, right? They have not mentioned neither fever, night sweat, or lymphoma, right? So this is less likely. Germ cell tumor, again, germ cell tumor usually not a hepatosplenomegaly, usually not there. They present may probably, right, in a child with they present with a testicular swelling, right? There is a no LDH, beta HCG, nothing it is given. There is no mediastinal swelling or mediastinal widening or mediastinal lymphadenopathy, other things, right? So this is a classical case of Langerhans cell histiocytosis. If you open up the book, it is known as LCH, Langerhans cell histiocytosis. It is though not a common question, but it is very important. They may ask you. Let me tell you one excellent triad which is very I like this trial. Now onwards, whenever you are doing any MCQ, any exam, USMLE, PLAB, NCLEX, or whatever exam you are giving, or DHA, HAD, MOH, or any exam, MRCP, you need to know three things for any MCQ. First thing is what is the diagnosis of this MCQ, how you investigate or how you gonna approach this patient to reach up to the diagnosis that you know. So once you do the investigation, you do the diagnosis, and third thing is how you gonna treat this patient. right? So you must know all these three things. If you cultivate the practice of knowing the three things in one MCQ, I will guarantee you, you will pass in any exam, any exam. So you don't need to remember or mug up answer to answer. They may change the scenario, they may change the this all clinical scenario or vignity. But if your basics and logics are clear, right? You clear cut diagnosis, clear cut how you investigate and how you treat. They three ask only these three questions in any exam, irrespective. You name the exam, these three things will be there. So here what they are asking diagnosis, right? If they had given okay, Langerhans histiocytosis, the diagnosis, what is the treatment now? Then you have to think of treatment part as well. So let's see. This is the Langerhans cell histio. Let me tell you where is the what is Langerhans basically. So this is epidermis is basically the skin. So this is you need to know the normal things. Then unless you know the normal, how do you know the abnormal? So this is normal Langerhans cell, Langerhans cell histiocytosis. This is how the name comes. So this is all skin layer, right? You can see dead keratocytes, right? Keratinocyte, melanin, melanocyte. If it is tumor arise from melanocyte, it is called melanoma, malignant melanoma. If it is arise from Merkel cell tumor or Merkel cell carcinoma. If it is arising from basal cell, right, baseline, it is called basal cell carcinoma. If it is arising from the squamous cell, it is called as a squamous cell carcinoma. So no need to mug up. Whatever the layers or whatever the histology or whatever the cell involved, they give the name. That's it. So squamous cell involves squamous cell carcinoma. Basal cell involves basal cell carcinoma. Merkel cell, melanoma. That's it. So Langerhans is the normal cell. It is in the epidermis. So there are two main manifestations in skin and bone. Skin and bone. These are the two most commonest presentation of Langerhans cell histiocytosis, right? So any scenario when you are giving the answer of Langerhans histiocytosis, look, is there any bony problem? Is there any dermatology problem? If it is yes, more likely, which is less commonly in leukemia, lymphoma, I treated thousands of patients so far in 20 years. Skin involvement is very less and bone involvement per se is very less. Many patients have leukemia patient have bone pain, but otherwise bone is fine, right? Where in Langerhans cell histiocytosis there is a skin and bone involvement. So now go back to this scenario. What they are asking in our scenario, right? So 2 years old child come with the ear discharge, seborrheic dermatitis. See the dermatitis, right? So this is very common, right? Things, and this is classical presentation when this Langerhans cells gets deposited, right, in the liver spleen, hepatosplenomegaly can also be seen. So now this is the things. Langerhans histiocytosis, pulmonary Langerhans cells histiocytosis, diffuse lung disease that primarily affect young adult with cigarette smoking playing a significant role in development of disease. How is the clinical picture of LCH? Pain, swelling, or lump in a bone that does not go away. That is one thing. Broken bones from a minor injury, loose teeth, or swollen gums. Ear infection. This patient has a ear infection or ear discharge. Ear discharge. This patient has a ear discharge, right? So that is also matching, right? So ear discharge is also there. So ear infections or discharge and skin rash. This patient has seborrheic dermatitis. So skin involvement is also there. So this is looks like a classical LCH patient, right? Presented with these things. And last, as I told you, my triad three things: diagnosis, investigation, and treatment. How you diagnose? You take a biopsy from the concerned organ. Either you can, if it is lymph node enlargement, you can do lymph node biopsy, you can do bone marrow biopsy in cytopenia, you can do the dermatology manifestation is there, you can do the skin punch biopsy. So from the biopsy, you can see lots of numbers of Langerhans cells in the microscope. So Langerhans cell histiocytosis is a rare disorder that can be damage tissue or cause lesion from in one or more places in the body. LCH is a rare disease, begins in LCH cell. I shown you where is the LCH cell. So this is a like octopus, it's a LCH cell, right? So this is LCH cell. LCH cells are a type of dendritic cell. And what's the normal function of these cells are to provide the fight against infection. So it's an immune function. So if there is LCH, immunity is compromised, patient may present with recurrent infection of skin, of eye or ear or anywhere, maybe lung, pneumonia or UTI. So infection is most commonest presentation, and how you gonna treat this patient? What is the treatment of choice for LCH? The standard therapy for LCH is vinblastine and prednisone. So vinblastine is a chemotherapy and prednisone is a steroid, right? So it is a primary treatment, and you may add methotrexate and mercaptolurine. That's it. So this is how we have to think of this LCH. So that's it. So this is the second question. You can check out your score. How, what's your question and what's the real answer? So third question is in front of your screen. Heparin, if you are not asking means I considered or take it granted that you understood everything well, right? So if you have any queries, please stop me. We'll discuss. Heparin is the commonly used anticoagulant in cardiac surgery. All of the following are true about heparin except means you have to concentrate on this word. Except means it is not there. So everything is true. One is not true. What is not true? So this they are talking about heparin. So heparin is weakest acid found in living being. Most commercial preparation of heparin are being derived or produced from the pig intestine. Heparin acts via antithrombin activation, or heparin produce thrombocytopenia. That's it. So this is what the question is. So you think over it. I want and wish everybody post the answer, right or wrong. I'm not worried about right or wrong, but at least post the answer. So if the same question comes in exam, you have to write something. You can't keep it blank. Not a good idea to keep any questions as blank. Your marks is gone. So whether right or wrong, you have to answer. Yes, anyone, any volunteer. Yes, any volunteer, any comment.
I think it could be weakest acid. That is the wrong answer.
Sorry, what could be the answer, sir?
Weakest acid A could be the answer for that.
Yeah, so that is not there. So weakest acid form in living organism, rather it is the strongest acid form found in the living organism. So rest of the all three statements are correct for your knowledge. So we will go bit in detail of heparin because it is very frequently used drug in ICU and non-ICU as well. So heparin is an anticoagulant drug, right? Which stop the clotting. So it's an anticoagulant drug. So what is true about heparin? Yes, heparin is a derived from the pig intestine, it's correct, right? So this statement is correct. XY antithrombin 3 activation, yes, so it activates antithrombin 3 and make the anticoagulation effect. It cause heparin cause thrombocytopenia, yes, heparin cause thrombocytopenia, we known as a HIT, heat. If you know heat terminology, heparin induced thrombocytopenia. There are two type, one heparin heat 1 and heat 2, right? This is non-immune and this is immune. So we'll see in the couple of questions as well. So heparin is absolutely can cause heparin-induced thrombocytopenia. So it is also correct. What is not correct? Weakest acid. So it is not weakest acid. It is a strongest acid. Means strong acid found in the living organism. So answer is this. Now let me give you the little more clarity on this. Right? Heparin is compound with strong, not weak, strong acid strength, which compromise of acetic complex of glucuronic acid and glucosamine. No need to remember, just for your MCQ purpose, I posted this. Right? So just remember this. This is what the if the things comes in exam. This is very extremely important. Lots of people are confused between heparin and warfarin. So let me give you complete clear cut demarcation and complete clear cut distinguish between heparin. So what is the heparin? So heparin acts on the intrinsic pathway, and let me draw and tell you this is one of the most easiest, which is absolutely 100% confusing from day one from our medical graduate. I was also confused before being a hematologist. So I will give you a very complete clear cut idea about this pathway. If you listen me next 2 minutes, You can answer any intrinsic, extrinsic pathway. This is extrinsic pathway. This is intrinsic pathway. I will give you complete, excellent, clear-cut picture now today. In extrinsic pathway, there is a factor 7. It is usually written in Roman word, but I am just putting it here. So remember in a most simplest way, 7 is here, 8 is here, 9 is here, 7, 8, 9. Where is 10? So 10 is here. 2 multiplied by 5 is 10. This is how I remember. So I'm giving you the most easiest formula to remember this extrinsic. Otherwise, if you mug up 100 times, you will forget. So 7, 8, 9, 10, 11, 12, and here is 13. That's it. This is the pathway. This is the pathway. I will explain you more in detail. So this is clotting factor 7 is in extrinsic pathway. If somebody is talking about factor 8, it's in intrinsic, 9 intrinsic, 11 intrinsic, 12 intrinsic. So what happens basically when there is an internal injury or when there is an external injury, there is an activation of this pathway which God has given, right? So factor 7, if it is extrinsic pathway, factor 7 convert in 7A, right? And 7A eventually activate factor 10, 10 to 10A, and you need a factor 2 and 5, right? So this is called as a common pathway. This is common pathway because this is in intrinsic pathway, that is an extrinsic pathway, and this is a common pathway, right? So 2, 5, 10 along with the calcium comes in the clotting cascade. So what happens, right? Even if you are having coming from this pathway, you are coming to common pathway. If you are coming from this pathway, you are coming to common pathway. So eventually, when you come to the common pathway, what happens? Factor 2 prothrombin convert into the thrombin, and this thrombin will cause fibrinogen to fibrin clot. That is factor 13. Fibrin clot or fibrin stabilizing factor, that is factor. So this is most simplest form of coagulation cascade. So you don't need to remember, you don't need to mug up, sorry, right? Now this extrinsic pathway, how you monitor extrinsic pathway? By one test called as a PT, prothrombin time. How you monitor intrinsic pathway? It is called APTT, activated partial thromboplastin time. So if somebody is saying something wrong in the PT, don't never ever think of factor 8 because factor 8 is not coming in extrinsic. Extrinsic means PT, intrinsic means PTT. So something goes wrong in factor 8, factor 9, factor 11, factor 12. APTT will elevate, APTT will increase. Now I will see if there is a factor 8 deficiency or mutation or something wrong in the factor 8, we call it as a hemophilia. Hemophilia. Have you heard of it, this doctor? Yes or no? Are you with me? Yes or no? At least tell me yes or no, right? Factor A deficiency, hemophilia A. This is hemophilia B and this is hemophilia C. So no need to mug up, no need to mug up. Hemophilia A, factor 8 deficiency, hemophilia B, factor 9 deficiency, factor 11, hemophilia C. So if hemophilia patient comes to you and they ask you what abnormalities hemophilia A will have, what happens to PT and APTT? So PT is normal. Why? Because it is in the intrinsic pathway, right? Not in the extrinsic pathway. So PT is normal, obviously, because factor 8 is not in extrinsic pathway. It's in intrinsic pathway. Intrinsic pathway is monitored with APTT. So PT is normal. APTT will be high. That's it. Same thing with the factor 9, 11, 12. That's it. What happens when there is a common pathway involved? If there is a factor 10 deficiencies developed in some patient, congenital deficiency of factor 10, then probably PT and APTT both will increase, right? Because PT also affected, APTT also gets affected. So PT and APTT both will affect. So whether factor 10, factor 2, factor 5, anything gets affected, common pathway, both the things will merge, so both the things will get affected. So this is what the thing is, right? So complete any drug, any anticoagulant drug, right? It acts on at this level, at this level. So you need to remember this pathway. until and unless you remember the basic this pathway, you always get confused. What drug acts on what level and what factor? So far, it is clear, yes or no? Viral, is it clear or no?
Yes, sir.
It's clear.
Sorry, so far clear, right? If I'm not wrong. Great, wonderful.
Yes,
So this
sir.
is what the most simplest form. So no, you don't need to remember. This is little complex, but I tried my level best to make it little easy. So remember in this way. Let's come to the drug. So if you know the basic things, you will enjoy while practicing things. While we are giving low molecular weight heparin to many patients in our OPD, IPD, indoor ICU, but we don't know where exactly the Clexane, low molecular weight, enoxaparin, fendoxaparin, where exactly it acts. So now this is again the same chart, but little looks complicated, but the same thing. Let me draw your attention. See here, this is they making extrinsic pathway. See, so 7 is the extrinsic pathway, right? Again, you can here see, right? Factor 9, factor 11, factor 12 as we draw. This is 8, 9, 11. Where is 10? So this is 10 is in the common pathway. This is the same picture I draw it, but it is little in a different way. So now see the drug warfarin, right? It's an oral anticoagulant drug. Warfarin we are using for many cardiac patients, valvular surgery, valve replacement patients, deep vein thrombosis, pulmonary embolism, and any deep vein thrombosis or clotting. We use the warfarin, right? And it is one of the most oldest drug comes in the market for years and years. Warfarin or comudin is used. So basically, you need to know no, where the warfarin acts. So there are four factors. Warfarin acts on 2, 8, 9, and 10. So see here, factor 2, it acts on 2, 10, 9, and 7. Sorry, 2, 7, 9, and 11. These are the drug. So right, so what happens, right? So when you give the warfarin, it inhibits all the factors. And when you inhibit, proper clotting is not formed, and that is why it is an anticoagulant drug, right? It inhibits the clotting, right? So warfarin is oral drug, it acts on this, right? Now very nice trick I'll give you. XA, can you see apixaban, adoxaban, rivaroxaban, XA? So simplest form to remember, XA, X means 10, A means activation. So it acts on the factor 10. So can you see this all three drugs acts on factor 10. So wherever there is a XA comes, right? Apixaban, endoxaban, rivaroxaban. So XA is designed in that way just to remember, right? So any XA means factor 10A activity is inhibited by this or all band, right? Apixaban is very commonly used in practice. Rivaroxaban is also very commonly used in practice, right? So this is a drug, right? So we seen the warfarin 2, 7, 9, 10. It acts this all band acts on the factor 10A activity. Now comes to the heparin. So this heparin is anticoagulant, antithrombin 3, right? So it also acts on 10A as well as in 2A. It inhibits both the things, and dabigatran, again it's a oral, newer oral or a direct oral anticoagulant drug comes in the market, dabigatran. So that is also act on the 2A activity on the common pathway. So these are the common things. One is oral anticoagulant, one is a IV anticoagulant. So let's see little difference. So you need to know simply, right? I don't want you to do a PhD on clotting cascade, but at least when you are using any drug in your clinical practice, you must know where it acts, right? So you enjoy more, right? So now onwards, when you give somebody Clexane or heparin, you should know that okay, fine, it inhibits the factor 10 and 2A activity, and that is how it helps in clotting or acts as an anticoagulant drug. That's it. So this is again a very interesting different. So I started here and gone to that chart. So heparin, as I told you, now you know heparin where it acts. Heparin acts on the, again you need to keep this picture in mind. Heparin where it acts 10 and 2, right? So it's an anticoagulant 10 and 2, right? So heparin acts on the intrinsic pathway. See, intrinsic pathway and common. It's intravenous. Oral form of heparin is not available. That is why we are not giving heparin tablet. It's not stabilized in GI tract. So it is intravenous, does not cross placenta. It's very important. Why it's important, right? Because if it cross the placenta, it affects the baby. So any pregnant woman comes with pulmonary embolism or deep vein thrombosis or anything, which could be the safe drug to give as anticoagulant in pregnant woman, then answer is heparin, because warfarin is crossing the placenta and it's teratogenic, means it may cause the development, fetal development abnormalities, right? Or limb problem, or there are a lot of teratogenic activity or fetal development is disturbed. So warfarin is not a good drug for a pregnant woman. Normal, it's fine. For pregnant, especially in a first trimester, because all cardiac functions, limb, pulmonary, everything gets generated. And if it gets suppressed, patient may have congenital malformation. So we need to know it's important. So heparin is a drug of choice in pregnant and non-pregnant, right? While it is not a good drug in pregnancy because of teratogenic activity. Rapid onset of action. When you give the heparin, it's acting fast. While you give the warfarin, it takes 3 to 5 days for its effect to start. So what happens when some patient morning today comes with calf deep vein thrombosis to me? What I'll do? I will start low molecular weight heparin as well as I will start the warfarin. Both I will start, right? Because warfarin will not act immediately. It takes 3 to 5 days to have its optimal effect, or it will take INR to become a 2 to 3. That is a therapeutic range. We call it as a therapeutic range. Normal INR should be 1. If I do, or if somebody is not on warfarin, INR should be 1 to 1.2. That is normal. But when you are trying to achieve the anticoagulant effect, your goal should be 2 to 3. Valvular heart replacement, mitral valve replacement, goal is 3 to 3.5. So then and then you get the anticoagulant effect. So I start this low molecular heparin, it start acting in 2 to 6 hours, right? So it is an immediate effect, and this take 4 to 5 days. So once the therapeutic effect will achieve, means warfarin 2 to 3 INR comes, then I will stop the this low molecular weight heparin, because it is given subcutaneously. Doctor or nurse has to go to the patient's home every day to inject this injection, right? And many a times it is a twice a day, not a OD or once a day. It's a twice a day, BD, bice a day. So it's little difficult. So visually, any clinician, they start with the low molecular weight heparin in 3 to 5 days. They switch to warfarin, and depends on the indication. Any deep vein thrombosis, you at least start 3 to 6 months oral. Any anticoagulant, whether you start warfarin or you start the apixaban, rivaroxaban, dabigatran. We have seen many drugs earlier, right? So you need to continue. Another advantage is few drug interaction, and this is many drug interaction in warfarin. You cannot give with pentodex, you cannot give with sulfa, you cannot give with long list of antibiotic, antituberculous, rifampicin, lots of drug interaction. So you need to check, or if something goes wrong on warfarin, you check two things. You check other drugs of the patient, as well as you check the dietary history of the patient, because diet is also very important, because lots of things which increase or decrease the effect of warfarin. So you need to check when something goes wrong to the patient, otherwise fine. And antidote of heparin is a protamine. You must know, this is MCQ exam question. And warfarin antidote is vitamin K. Vitamin K. So any patient in emergency with warfarin comes with a 5 PTINR, means very high, right? With bleeding, you give immediately vitamin K, because vitamin K is the antidote of warfarin. So that's it. This is what the basic things you must know for warfarin and heparin. Probably you enjoyed. I try my level best to make it more simplified. And it is one of the most commonest drug used in ICU, OPD, indoor, warfarin in a lot of OPDs, and lots of patients are on anticoagulant drug for deep vein thrombosis in especially lower limb or pelvic or upper limb. Any question? Any questions with this? I would be glad to answer. Any questions, Dr. Shafi? Any question?
Nothing, because
Sorry? So I think all clear, right? So I'll jump on the next question. Is that correct?
Okay.
Wonderful.
Okay.
Wonderful. Wonderful. Next question. So this is how you remember. I mean, it is not mandatory that whatever I'm discussing that will comes in exam. That is why I'm discussing the scenarios nearby. So whatever they ask in the exam, you can easily, comfortably ask or place the answer properly, right? So this is what otherwise this PowerPoint will I can finish it in 30 minutes. I'll read blah 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 blah. This answer, okay, lecture is over. But you won't grab anything. This is properly understanding. You can get some ideas, you can get some. See, otherwise, believe me, this is one of the most horrible picture when I was in MBBS. This is exclusively very scary picture for me because I mean we don't have the concept now how does it work and how it works. But now practicing, we get to know the real story. So now it looks very easy for us. Fine. Next question: patient with iron deficiency anemia is being treated. Very simple question. Patient with iron deficiency anemia is being started on treatment with oral ferrous sulfate. We amongst which of the following is earliest indicator of response to oral iron? So simply, I'll make it in a simpler word. You have one patient who has iron deficiency anemia. You started oral iron. Now you want to monitor the response of iron. What is the parameter by which you know that okay, fine, this iron deficiency is improving, or patient is improving, or this iron is acting on the patient? So by increasing hemoglobin, you are more comfortable, or reticulocytosis, right? And they are asking one most important word is earliest indicator. Earliest means what could be the earliest indicator which suggests there is a response of oral iron. So increase in hemoglobin, reticulocytosis, normalization of serum ferritin, or increase in MCV, that is mean corpuscular volume. Yes, your time. Start. So what do you think? You have one patient of iron deficiency. You started iron, and patient is asking after 3 4 days, sir, am I improving or not? Then how do you get to know, or how you convince the patient, okay, okay, don't worry, you are improving. This is the parameter by which I know you are improving. What's that parameter? Yes, Dr. Raksha, any comment? I would like to hear from you. Yes,
Sir,
probably you,
reticulocytosis.
no problem. You don't shy. You answer, don't worry.
Uh,
Yes, so your answer is absolutely correct. There is no doubt. This is a
sir,
reticulocytosis.
within
Yes,
5
tell
to
me.
10 days, after you start iron therapy, it will increase.
How
The
many days, doctor?
I think within 5 to 10 days, the
Great.
after you start the iron therapy,
That's correct. You are correct, doctor. Right. So this is the official chart I'm giving you just for knowledge. Right. So when somebody has iron deficiency anemia, right? So what happens? Time after iron administration. So you start patient has iron deficiency anemia. You started iron to this patient, oral iron, say for example, you started. So what happens after starting? So in first 24 hours or in one day, they are little clinically improved, decrease irritability, increase appetite. So this is clinically, you get little better clinically because and supplemented, right? Physically, you get better. What is second most important thing? 48 hours. So 1 to 2 days, 48 hours means 1 to 2 days. Initial bone marrow response or erythroid hyperplasia. But we are not going to do bone marrow biopsy on day 2 or day 3 just to assess the response. So it's not a good test. But just for your knowledge, it is important that the one is clinical, then earliest is bone marrow, and after bone marrow, 48 hours means 2 to 3 days of time. The most important thing increases the reticulocytosis count. So 3 days it will start increasing, and at least 7 days it is on the peak, right? So what I do in my practice usually when any iron deficiency patient comes, I put it on oral iron, PO iron. On 7 or 8 day, I ask for the I tell the patient to come, right? I see clinically how is improving, fine, and I do one simple test, retic count, right? Initially, when there is iron deficiency, anemia retic count is say for example 1%. But once you give the iron, lots of red blood cells are generated and retic count is also increased. So this 1% may probably 5%, probably 10%. That suggests the response of the oral iron in the iron deficiency anemia, and it is a blood test, simple blood test. Result will come in 1 hour, 2 hour. That's it, right? So it is most easily convenient, available, and cheapest test as well. So this is very well accepted. So I don't do hi-fi test for patient and spend a lot of money of patients in doing iron profile and iron TIBC, ferritin, blah blah, all fancy. Just do the retic count if you are monitoring the iron deficiency anemia and you want to know the response. And after that you can see after, I mean, 4 days to up to 1 month, you can see increase in the hemoglobin, right? And lastly the ferritin will increase. So this is the pattern. One is a clinical, first is a clinical improvement, second is a bone marrow improvement, third is a blood or retic improvement, fourth is hemoglobin, and last is ferritin. So ferritin, once everything complete erythropoietin is done, then your goal is to increase. So say for example your hemoglobin is 5, example, right? And ferritin is 15, right? And you confirm that it is iron deficiency anemia. So first clinical improvement, retic will increase, bone marrow will improve, retic will increase, then hemoglobin, and lastly the ferritin will increase. And your goal is not just to normalization of hemoglobin from 5 to 13. This is the this is the most common mistake clinician do in practice, especially GPs and general physician. So being a hematologist, what I'll do, once it is 13 I will not be happy. Once the hemoglobin achieve to the normal, I'll give 2 to 3 more months oral iron or IV iron, whatever, to the patients, right? More 2 to 3 months. This 3 months, the hemoglobin will remain same, 13, 13.5 nearby. But excess iron after normalization of hemoglobin, it increased ferritin from 50 to 100, and that is the iron store. So if you have good store, in future, if anything goes wrong, right, anemia will not develop, ferritin will utilize 100, 90, 80, 70, but your hemoglobin will stay 13. When the complete ferritin is empty or severe iron deficiency anemia, then you fall the hemoglobin, right? So our goal is not just to normalization of hemoglobin, our goal is to make the ferritin normal, make the ferritin normal, not just the hemoglobin. So I never get happy that, oh, now your hemoglobin is 1230, you go home, enjoy, don't worry, everything is fine. I will not leave the patient till the ferritin is increased. So I give usually 2 to 3 months, depend on the patient to patient, right? But at least give 2 to 3 months of extra supplemental iron to replenish the proper store of the ferritin, which prevents the further development of iron deficiency anemia. That's it. Dr. Raksha, I think you got my idea, right? What I'm trying to explain, yes or no?
Yes, sir.
Is that clear to you or any confusion?
Yeah. No, no, yes, sir. Thank you. Thank you for the information.
Wonderful, wonderful, wonderful. Probably this will help you in your clinic, doctor. And iron deficiency is one of the most common anemia across the globe. I've been to UK, US, Australia, India, Kenya, Nairobi, wherever you go, iron deficiency is the number one most clinical practice. Iron deficiency anemia is the most common, and second most common in any country is anemia of chronic disease. ACD, anemia of chronic disease, and deficiency. This is the most common. So this is the differentiating point, how you differentiate iron deficiency from anemia of chronic disease by iron profile. So you just go and read. I will give you homework, right? How you differentiate by iron profile, iron deficiency, and anemia of chronic disease. Very important and very easy as well. So I'm not going much in detail, and I'll move to the next question. That is also very easy for you. Just we discuss best test to detect the iron deficiency in a community with low prevalence of iron deficiency anemia. So which is the they what they ask best test. So they are asking what is the best test to diagnose iron deficiency anemia? PEC cell volume, iron binding capacity, or you can see TIBC or total iron binding capacity, or serum iron or serum ferritin. So which is the best test by which you know that okay, TIBC is the best test, total iron binding, serum iron is best test to know the iron deficiency, serum ferritin is the best test to know the iron deficiency, or PCV means packed cell volume. So what is the test which gives you the idea that the okay, This is the test by which you know this is iron deficiency. Yes, Dr. Raksha. So that's perfect. You are right. So ferritin is the best test. So when the ferritin is low, that is iron deficiency. That's it. There is no differential diagnosis of low ferritin. Only one differential, iron deficiency. So any patient, if you feel that this patient is iron deficiency anemia, do the serum ferritin. Simple. Do serum ferritin. If ferritin is less than 50 in a female, less than 50, it is considered as a iron deficiency. That's it. There is no differential diagnosis of low ferritin. It's iron deficiency. You need to figure out what is the cause of the iron deficiency. It's different. Whether it is a nutritional iron deficiency or it is a GI blood loss, excessive menstruation, multiple pregnancy, blah blah. There are a lot of causes, but still, only one diagnosis for low ferritin is iron deficiency. That's it. So this is the test. So don't get confused yourself, right? So this is all high yield points for practice as well as in exam. Next question in front of your screen. A patient with CKD, that is called chronic kidney disease or chronic renal failure, found to have hemoglobin of 8 gram on investigation. Which amongst the following is the best possible treatment? So you have one chronic kidney disease patient with hemoglobin of 8. So obviously it is less, right? It is a mild to moderate, not mild, I can say moderate anemia, right? So what is the best possible treatment? So again, right, you need to know the triad. If you know the triad, diagnosis, investigation, and treatment. So here diagnosis they had given, right, chronic renal failure, CRF, right? They are saying that investigation shows that is the H gram of HB. Now they are asking the treatment. So what is the treatment? They are asking the best possible treatment. Oral iron, blood transfusion, parenteral iron, erythropoietin. That's it. So you need to justify what is the best. You need to justify what is the best. Yes, Sultan. Why you want to give oral iron? Sultan.
I'm Bahar. Because I think this hemoglobin is having MD delight is important for me for transplantation or for parental iron, but is 8 level is okay.
Okay, so but what makes you to think give oral iron? Is it iron deficiency anemia? Do you think it's iron deficiency anemia?
Yeah,
Because you
yes, it
posted
is
A,
anemia,
so it's a
but
oral.
not only transfusion.
Sorry.
Yeah, it is exactly anemia is 8 level, but is no need blood transfusion.
Yeah, blood transfusion no need. So I'll remove the blood transfusion. Let me help you to exclude the things one by one, right? So blood transfusion is no need. Okay, fine. Now select amongst three. Now you have three options. One is gone absolutely. Now you give oral iron, you give parenteral iron,
Yes,
you give erythropoietin.
maybe.
Sorry.
Uh, that patient kidney disease, not liver disease. If he has it has liver disease, I want to give erythropoietin, but it's just kidney disease. He used iron, oral iron. He can use.
But this patient does not have iron deficiency. No? What deficient in chronic kidney disease? What is absent in the chronic disease? Doctor, I'll explain. Don't worry. Harold.
Kidney can't produce erythropoietin if there is CKD.
Excellent. Excellent.
Not
Excellent.
sure.
So yeah. Go ahead. Sorry.
Yeah. I will think.
Fine. So this is Dr. Bahar Toprak. This is not iron deficiency anemia. See, there is a no serum iron they had given. They had not given TIBC. They had not given ferritin. Nothing. It is not suggestive. And they had given one chronic condition, chronic kidney disease. So this is until proved otherwise anemia of chronic disease. So whenever they give you CKD means chronic kidney disease, CLD chronic liver disease, chronic hypothyroidism, right? aplastic anemia, chronic bone marrow problem, chronic GI blood loss, blah blah. There are a lot of things, or chronic hemolysis or whatever. So chronic condition, you always think of anemia of chronic disease. This is how the name comes, right? And what happens in chronic kidney disease? Let me tell you very quickly, a simple thing, that the kidney, right? The kidney is producing one substance called as erythropoietin. 99% or so erythropoietin in our bodies developed from the or produced from the kidney, and this erythropoietin along with the other things which helps to create a erythropoiesis. Erythropoiesis means formation of blood or RBC. Erythropoiesis, right? So this help in erythropoiesis. Erythropoiesis, the simple word, it helps to form the RBC, new RBC, red blood cell. So what happens when the erythropoietin is not there? RBC will not form or hemoglobin will not form. So this patient become anemic. So what's your basic goal is to improve the erythropoietin level, which improves the erythropoiesis, which improves the hemoglobin. So almost every patient, you go and check it in your hospital and in your round, CRF patient, they usually anemic patient, and they all are on EPO, that is erythropoietin. Maybe 10,000 unit per week subcutaneously, or max you can go up to 40,000 unit per week. This is the simple dose. So you usually start with 5,000 or 10,000. If there is no response, then go 20, 30, max is 40. This is how we escalate the dose. So chronic kidney disease, the problem is in erythropoietin. You want to supplement the erythropoietin, so you supplement the erythropoietin. If this patient has both the vigility, say for example, I mean entity CKD plus iron deficiency, it could be happen. So in that case, you supplement the iron, oral iron or parenteral. If not tolerated oral, then subparenteral, but usually oral iron. If tolerate well oral, if not tolerate well, then IV iron, right? So you can give both iron plus erythropoietin in the same patient, but they have not mentioned anything, Dr. Bar, for iron deficiency. So this is classical case of anemia of chronic disease, right? That is chronic kidney disease. So supplement the erythropoietin, not the oral iron. And blood transfusion is usually not required in a minimal symptomatic patient. If it is less than 5 or patient is very much symptomatic, right? In that case, you can use the to fast increase the hemoglobin, you use the things as well, this blood transfusion, but it is reserved for the emergency in any patient. So it is not a routine product that, okay, fine, low hemoglobin, you transfuse the blood. It's not the practice, right? Dr. Hiral, is that okay with you?
Yes, sir, it's clear now.
Very clear now. So
I got
1%
it.
of the sorry.
I got it.
Okay.
I understand.
So yeah. So you got the idea, Dr. Bar, right?
Yes.
Or not? Right.
Uh,
So great. You are a brilliant. So not a big deal. You will catch up. Wonderful. So probably I think you get confused by your own. That is what I think. So you knows the answer, but still you confused. And that is what the main practice we need to know. Most of the doctors, most of the exam aspirant, they know the answer, but we are confused ourselves. This or that, A or B, B or C, C or D. So it makes problem in the exam. So bring more clarity. That's it. Right. So this is all story about erythropoietin. So I will not go in much detail. I will later on discuss with you. Right. Now this is little tricky, not very tricky, but important. Learning would be there. I will make you expert in uh, this hemoglobinopathies in this question. A 20 days old neonate has recurrent episode of jaundice with unconjugated hyperbilirubinemia. Peripheral smear shows increased reticulocyte. There is a family history of anemia and jaundice. Which of the following is a likely diagnosis to this patient? Sickle cell anemia, beta thalassemia major, neonatal cholelithiasis, hereditary spherocytosis. My question is, what is likely diagnosis? Based test and treatment. They are asking just diagnosis. I added two more things from my side, right? So once you diagnose by which test, what is the best test, and what's the treatment of the diagnosis. Your time starts now. You take your own time. Nothing urgent. I need an explanation rather than just answer. I want to see what's your thought process, how you get to know about the diagnosis. Yes, we have two, three more questions. That's it. So just be patient with me. Post the answer. Yeah, post. Dr. Saumi. Any comment, Dr. Saumi?
Sir, I was thinking sickle cell anemia.
Doctor, you are Dr. Saumi, right?
Yes, yes.
Okay, so now let's discuss what are the point favors in this scenario which makes you to think of sickle cell anemia. Tell me one by one. That okay, sir, this is the point in favor of sickle cell anemia. Tell me now.
Family history of anemia with jaundice.
Okay, family history of anemia with jaundice. So that is one thing. Okay, what else? Because anemia with jaundice, it could be present in many other conditions as well. Some septicemia you develop, or you may develop the some kind of hemolysis where you develop anemia and end product of uh, breakdown of RBCs, the bilirubin. So anemia with jaundice is also developed in hemolytic anemia. It can be developed. Why not thalassemia then? There is also hemolysis. Even beta thalassemia major has also family history because parents are minor, then and then develop the major. Why not it is thalassemia? Why it is this? Anyone, open for all. Anyone wants to comment anything, just comment.
See, the child shows features of hemolytic anemia with indirect unconjugated hyperbilirubinemia with jaundice.
Wonderful. So one thing is sure that this baby has some kind of hemolytic anemia, right? Because there is a anemia, there is a jaundice. When there is a, hemolysis, there
Indirect.
you may have hyperbilirubinemia, and that is unconjugated or indirect. So again showing hemolysis. Again, there is one more point in favor of hemolysis. Peripheral smear shows increased retic count. So what
Particular
are
cells.
the causes of increased retic count? When the production of RBCs is high, right? So when there is a anemia or when there is a fast this turnover, means breaking fast, hemolysis, hemorrhage, right? These are the two more common condition, right? So whenever any patient comes to your OPD, right, and you are thinking of hemolytic anemia, do simple again one test, retic. Iron deficiency anemia, do retic to know the response, right? If you feel that it is so in iron deficiency at the time of diagnosis, it is low, but when you give iron, it is high, right? Again, the hemolysis happen means what happen? There is a fast destructions of RBC. So what the bone marrow trying to produce is a retic count, very high retic count. It's a natural feedback mechanism. When your body needs it, right, your bone marrow makes it, right? So when there is any hemolytic anemia, autoimmune, non-autoimmune, drug induced, or infection induced, or DIC, or autoimmune hemolytic anemia, or whatever the reason, when there is a hemolysis, retic count is supposed to increase, right? That is a normal, natural response of the bone marrow to the hemolysis. That's it. This is common concept in hematology, right? So this patient has some kind of hemolysis, sir. So now you tell me what could be the answer or where it
Means all
the
these
most.
sickle, beta, and hereditary, all those are transferred. I mean, hereditary actually, I think.
Yeah, no, that is why I told you it's little tricky and interesting
Yeah,
as well, na?
all the
Complete.
three are means transferred genetically. So
Okay, so what you select, sir? What do you select, sir? If the
I
same
just
question comes
selected
in your exam.
hereditary spherocytosis.
Sorry,
I selected
hereditary spherocytosis.
spherocytosis, yeah.
Okay, so what
But it's not very
changed?
sure because the
No, no,
sickle
I
cell also.
understand. See, exam they will not ask you very sure or not sure. They computer will know correct or incorrect. So your answer is correct. That is correct. Your answer is correct. So you are done. Your
Yeah.
one MCQ is secured, right? But I want you to understand why it is a hereditary spherocytosis. Why not sickle cell? Why not beta thalassemia? Because same time I am asking here hereditary spherocytosis, but probably they ask you in exam for sickle cell. They ask you thalassemia major. So whatever they ask, I want you to answer correctly. I don't want to miss you the question. You understand? That
Yeah.
is why I'm
I
discussing.
think this early in the age when because just 20-day-old neonate presenting like that, it could be mostly more hereditary than the thalassemia and sickle cell.
Excellent. So that is one point, right? Another
Yeah.
point, beta thalassemia major when developed. Let me tell you little story, right? Beta thalassemia major is what? So beta thalassemia major when parents, mother and father both have minor, then and then beta thalassemia major will develop. What happens? Up to 6 months of life, up to 6 months of life, they have fetal hemoglobin. When the baby is in the womb, when the baby is in the womb with the placenta, right? When the baby is in the womb, there is a hemoglobin in fetal is a fetal hemoglobin. That is how it name comes, na? So when baby is in the womb or in uterus or in the pregnant area, their hemoglobin is F. Even after birth, when baby gets out, delivered, up to 6 months, this chain remains, right? This chain remains, this up to 6 months, this chain remains the HbF only, right? And after 6 months, it will convert into hemoglobin A, that is adult hemoglobin, right? So this shift of the chain occurs usually 6 to 9 months. And if this chain shift is, this is normal process in you and me, same thing. When I was in fetal life, I have hemoglobin F, that is 99% hemoglobin F, right? But when it is become hemoglobin A or adult hemoglobin, it is 95% and F reduced to less than 2% or so. This is normal process. But what happens in normal process when the hemoglobin F does not get converted into the hemoglobin A, then beyond 6 months, he has a hemoglobin F of 95%, which is not supposed to be there. And that is thalassemia major. So thalassemia major usually not evident before the 6 months of age. Is that clear? Yes or no? Tell me at least yes or no.
Very clear. So it's understand very yeah.
Right? So thalassemia is gone. I mean, in general, 6 months, 20 days, they never develop anemia, right? If it is a 20 days anemia, never think of thalassemia major or any thalassemia. Why? Because this is developed after 6 months. So after 6 months, how the mother comes to the doctors or pediatrician, sir, my baby is not playing well, he looks pale, is failure to thrive, weight is not gaining, it's thalassemia or iron deficiency. That is most common is iron deficiency, then thalassemia. Anyway, so this is the thing, right? Now sickle cell anemia. Let's see the sickle cell anemia. So sickle cell anemia is usually the anemia. There is a hemolysis, obviously, right? So this is a normal shaped RBC. It is a dumbbell, normal. This is normal RBC. What happens in sickle? It is become a sickle. This is a sickle. This is sickle cell RBC. So what happened? This is extremely flexibility because of the cell membrane and enzyme, right, which gets distorted because of genetic single gene defect, right, and that cause the sickling of the RBC, and this sickle will not pass from the small vessel, right? So dehydration, hypoxia, drug, and infection. These are the four commonest things which makes sickle into the crisis. So if sickle cell patients are living normal, they are like you and me, moving around, playing, eating well, socializing. But this sickle, when they get dehydrated, again there is a when dehydration, intravascular volume is reduced, They get sickle, and they cause vaso-occlusive crisis. Vaso-occlusive. Vaso means vessel, occlusive means obstructions, and crisis means crisis. So when there is a dehydration, when there is a hypoxia, when there is a infection, there is a vaso-occlusive crisis. Just hold on for 1 second. I got a call from emergency. Huh? 1 second. Yeah, sorry. So this is what the pathophysiology. So they may develop, I mean, anemia and jaundice, right? But at the age of 20 days, again, it is not favor in sickle cell, right? Again, because hemoglobin F is a protective, right? Hemoglobin F is a good up to 6 months of age. So again, they never develop, I mean, 6 months of age or immediate neonatal phase. Sickle cell will not develop, right? So that is again in not in favor. Neonatal cholelithiasis, there is nothing showing cholelithiasis. And in cholelithiasis, you develop just jaundice. You don't develop the anemia, right? And in cholelithiasis, you won't increase the reticulocyte count in peripheral blood. So most fitting answer is a hereditary spherocytosis. So what is hereditary spherocytosis then? So let me tell you one more minute. So this is normal RBC as I shown you in my picture. So this is the normal RBC, right? So RBC is like dumbbell by, this is a different angle picture, but it is dumbbell shape by concave shape RBC. It converts now into spherical shape. It's like a ball, right? It's a cricket ball, football, like spherical shape. That is why the name comes hereditary spherocytosis. A heterogeneous disorder where abnormalities of RBC structural protein leads to loss of the RBC membrane surface area. So it should be supposed to be like this because of there is a defect abnormalities in RBCs, loss of RBC cell surface membrane. Instead of this, it becomes this. Again, the same problem in sickle cell, it is like this. So neither sickle nor this spherical will pass very smoothly, easily from the blood vessel, especially the smaller blood vessel, right? So this what happens in the blood vessel, it not gets properly passed, so it obstruct, it rupture, and that is why they develop with the hemolytic anemia. And then there is a hemolysis, there is the excessive production of the bilirubin. Bilirubin eventually causes a gallbladder stone or GB stone, right? There is a jaundice because of bilirubin, because of hemolysis there is a anemia, and because of excessive spleen has to work, there is a splenomegaly as well to the patients because of excessive hemolysis. These are the cardinal symptoms, and it is usual in the very early age of life. It is not something acquired, it's a congenital, it's a hereditary. So when the birth baby at the birth, within few days they develop, right? When the RBC gets break down, right, fast, somebody will see the peripheral smear, and this is a test, this is the diagnosis of peripheral smear. You, instead of this shape, you can see this shape. So there are lots of spherical shaped RBC in the peripheral smear, so it can be diagnosed immediately on the same day, right? When somebody see the peripheral smear under microscope, oh, this is not a normal shaped RBC, it's a sparocyte. Think of hereditary spherocytosis. And what is the base test? So here what the condition, recurrent episode of hemolysis. Yes, because the RBC wall is fragile, it gets break easily, not flexible, splenomegaly, gallstone or bilirubin stone is there. And most diagnostic accurate test is eosinophil maleimide, EMA. Just remember, it's a credit questions, right? So if somebody asks what is the best test to diagnose HS, it is eosinophil maleimide. EMA is more accurate than osmotic fragility test. And what's the treatment? Treatment, you cannot change the spherical shaped RBC, so just treat the symptoms. If there is a huge splenomegaly, massive splenomegaly because of recurrent hemolysis, you may do the splenectomy. That's it, which helps to reduce the hemolysis in such kind of patients. So that's it. This is what the thing is. And last questions for today. Let's discuss very quickly. Which of the following? So it's all clear, doctor. Sorry, doctor, all clear,
Yeah, yeah.
right? So our main goal not just to mug up the answer. We need to rule out each and every options in the MCQ. You need to cultivate that practice. So if you, I mean, obsolete one by one, right? You can remove, okay, this is not there, this is not there, this is not there, then this is answer. So even if you don't know the answer, but if you know the art of excluding one by one, you can reach up to the diagnosis or treatment or or correct answer, right? Because you develop, okay, 20 days thalassemia should be not be there, sickle cell not be there. Okay, then it could be hereditary, right? This is how. So when it happens, when you have little more clarity about the things, all right. So, which of the following organism cause infection following splenectomy? So, spleen is our largest, biggest lymphoid organ God has given in our body, situated in left upper hypochondriac region. Other lymphoid organs are the tonsil, Walder's ring, spleen, lymph nodes, blah blah. These all are the lymphoid and immune cells which helps to prevent the infection. Right. So, what they are asking, which of the following organism cause infection following. So if you did splenectomy because of any reason, whether it is a massive splenomegaly, malarial spleen, tropical spleen, trauma to the spleen, splenic rupture, lymphoma spleen rupture, whatever, right? Or planned splenectomy in chronic ITP. So which of the following organism can cause infection following splenectomy? E. coli, Klebsiella, Pseudomonas, or pneumococcus? Yes, Iral, what's your guess or answers? Yes, Dr. Swami.
Sir, pneumococcus?
Excellent. Pneumococcal. Excellent. So there are three kinds of encapsulated organism, right? So let me tell you, three this organism, encapsulated organism, which is culprit. One is a pneumococcal, another is a meningococcal, and third thing is Haemophilus influenza type B. These are the three commonest organism. When there is a splenectomy, we usually give the vaccine to pneumococcal, meningococcal, and Hib vaccine we give before splenectomy, or in case of emergency, if you want to do splenectomy, after splenectomy, you can give or administer this vaccine, because in splenectomized patient, increase of this, there is a very high risk of developing encapsulated organism infection, and these are the three major culprits, right? So you need to give before or after splenectomy this. If not, if it is planned, give before. If it is urgent, give after splenectomy. So here pneumococcus is the most appropriate. Pseudomonas, Klebsiella, and E. coli, it's all gram-negative bacteria or GNB, which is not very common in a splenectomized patient. Most common and deadliest is a pneumococcus. So you should give the vaccine against pneumococcus or pneumococcal. So this is what the literature is. That's it. And this is basic physiology of the spleen. So that's all for today. We'll cover the things next. So let me have a quick feedback from the audience. Right? What is the most important and fascinating for you today in the learning, which you did not learn during the class? Right? So what is the most important and fascinating for you today in the learning, which you did not learn during the class?
And
Wonderful.
you are a very good teacher, actually.
Thank you very much. Great. You motivated me for tomorrow's lecture.
Okay. Yes, sir.
Great. I'm self-motivated. This is my doctor, just for your knowledge, it's my more than 1,000 plus lecture I'm presenting to you, coaching for more than 10 years now, and I'm a hardcore hematologist. So probably this is my subject. So you probably enjoy it better because it's my subject. No? Main core subject is hemato-oncology. Anyway, but you understood the things in a simpler way, isn't it? What's your experience?
Yes, sir.
Great. So I want you to read once again. We have a lot of things to cover tomorrow as well. So let's catch up. Yes, Dr. Zainab, what's your quick comment? If you are in the class, what's your quick comment? Okay, Dr. Raksha, any comment?
Excellent, sir. You like the complicated things also, you made it easy. Like
Wonderful. This is
basics,
what my job is.
the
The
intrinsic
job of coach. Na?
exercise. Yeah.
Great, wonderful. Anything new you learned which you did not learn well in MBBS, or
Not on
or
MBBS, sir,
something which
even in
sticks
the
to your
I
mind, which is
practice.
which? Sorry.
Yes, yes, sir, that you told, right? The ferritin, even after it, like the hemoglobin, even if it's normal, still we have to give iron, oral iron for
Yes, that's correct.
2 to 3
Yeah, at least
months.
you give
So
just
that
to
ferret,
replenish the
that's
store. Otherwise, that same lady again present after. So now you are happy, okay, 12 grams. But again, after 6 months, it will come with anemia fit 7, 8 gram. Why? Because there is no store. So your goal is not just to improve the hemoglobin, to improve the store. That is ferritin.
that was a
Yes, Dr.
very
Safi.
important
Yeah, thank you very
learning.
much
Thank you.
for your feedback. Thank you. Yes, last
Yeah,
Dr.
yeah,
Safi, any comment?
yeah, yeah. Means it's not like mugging up. You make us understand the subject and easier to, means it reading enjoyable actually. So
Wonderful.
after attending your lecture, when you read it, you can easily catch things easily, and you don't have to much mug up, especially the thing you have given and the pathways and all. No, that is wonderful actually.
Thank you very much. Thank you very
That
much
means
for your
that. So I think I can solve more than 500 questions on that only. From that intrinsic
very good.
extrinsic pathway regarding warfarin, antagons, all von Willenberg,
Yeah, now I
hemophilia.
think probably your
No,
job is easy. I mean, if
yeah,
you read
means
by
if
your
you just
own,
give only
probably if
PT,
you,
hepatitis increase, PT
yeah,
increase,
yeah.
more than 100
Believe
questions.
me, yeah, believe me, when I was in MBBS, I was struggling to remember how to remember this cascade. I mean, it was so scary for me. But
Yeah.
gradually, when we super specialize, try to understand the things, then I always just, I mean, not praising myself, but I always try to make the subject easier rather than complicated. How I can make understand the people in a most easiest and understandable way so they can grab and remember for a long time. That is my main job. So I try to make it more simpler in my
And we
lectures.
can just imagine, we can just guess what happens when there is a what will happen when BT increase or hepatitis increase, when hemophilia is there, when von Willersberg is deficient. We can just make out no, easily.
Yeah, that's the
Yes.
story. That's the story. Okay, sir. Thank you very much once again, everyone, for your precious time. We'll see you soon tomorrow again with the next few more interesting slides of remaining hematology and probably the oncology. So thank you very much and enjoy your
Thank you.
evening. Good night.
Thank you very much.
Thank you very much.